Okay, I know there's still some people joining, but I'll go ahead and get us started. Good afternoon, everyone, and welcome to the panel discussion on substance use and disease risk. My name is Tim Nelson, and I'm a professor in the psychology department at the University of Nebraska-Lincoln. And I'm also the associate director of the Radar Center here at UNL. Thank you, everyone, for joining us today. I'd especially like to welcome our distinguished panel and thank them for taking the time to share their expertise with us. This should be a great discussion, and I'm honored to have the opportunity to serve as moderator. Our topic of substance use and disease risk is quite broad, and we could probably have 5 or 6 separate panels on different aspects of this critical area. As we all know, substance use can confer substantial risk for a variety of diseases, which contributes to the incredible toll that substance use takes on individuals, families, communities, and our healthcare system. So understanding the links between substance use and disease risk, and critically how to reduce health risks for persons who use substances, is an essential public health discussion. Before we begin that discussion, I want to give just a quick overview of the format for this panel. We will start with introductions, in which I will ask each of the panelists to take about 5 minutes or so to introduce themselves, talk just a little bit about their background and broad perspectives on the topic of substance use and disease risk. Then I will ask the panelists a series of questions to start the discussion. And my approach here is simply to get the ball rolling and then to get out of the way and let the experts talk. And so along those lines, I will encourage the panelists to take the discussion wherever they see fit, and to view my questions as mere prompts that should in no way limit them from raising any issues that they believe are important or interesting. And then finally, after discussion around those questions that I raise, the last 25 minutes or so of the session will be reserved for questions from the audience, which can be submitted via the Zoom chat or Q&A features. And I will admit that this is my first time moderating a virtual panel, so I'm extremely grateful to Callie and Devin, who will be helping me to monitor the chat and hopefully avoid any technical issues. But go ahead and submit those questions. We will save those for the final 25 minutes or so. And with that, I'd like to invite each of the panelists to introduce themselves, tell us just a little bit about their backgrounds and perspectives on today's topic. So I will work across my screen here and first start with Dr. Assoumou.
Hi, thank you for the invitation. So I'm Sabrina Assoumou. I am an infectious disease physician at Boston Medical Center, Boston University School of Medicine. And my area of expertise is looking at infectious complications of substance use, so HIV and hepatitis C, which are both transmitted by injection drug use. In terms of the work and the contribution that I've made, so initially, my team and I, we worked with the CDC to try to help the CDC come up with strategies for Hep C testing. And the reason why this question became important at the time was because we had new treatment that allowed us to actually cure patients. Unfortunately, a lot of the treatments were not used very widely. And so we were thinking about, okay, what are the strategies that we should implement so that we can actually cure patients? And so we did some cost effectiveness analyses and build models. And some of the take-home messages was that if we really wanted to increase the uptake of treatment, we really needed to have a pretty universal approach to screening. So because until you identify patients who are actually infected, you can't actually treat them. So having kind of a universal approach, not asking patients if they have any risk factors that would put them at risk for hepatitis C, but really testing more broadly so that we can provide treatment. And then after working on the cost effectiveness, I found that, by working with large data sets, I was often addressing and finding the problems. And what I actually wanted to do was think of solutions. We find that there's not enough testing, there's not enough uptake, but what is it that we can actually do in the community to actually improve those outcomes? So funded by the NIH, we went back to the community actually, and we went to a detox and we implemented HIV and Hep C testing to everyone. And we identified a lot of cases, but we found that unfortunately, there was very limited linkage to care. Although we had, we identified a lot of patients with hepatitis C, or we even identified one person with HIV, the rate of linkage to care was only 6%. So our next project was, why is that? So we went back to the detox and actually talked to patients and participants and asked them, what are the barriers and what are the things that are preventing you from accessing care? And we're actually using a lot of the information that we received to actually build models and of care to improve outcomes. So what is it that they told us? So number one, me as an infectious disease, I might come at it from, I want to cure your hepatitis C. I want to prevent you from getting HIV. But what we found is that for a lot of participants in our survey, their main issue was their active substance use, right? They were showing at the detox and they were not really interested in talking about Hep C and being cured from hepatitis C. They weren't interested in learning what I had to say about prevention. And so what that made me realize that as an infectious disease physician, until I have a comprehensive approach and actually learn how to treat patients for substance use, I am not actually going to get anywhere with implementing the tools that I think are really going to be helpful. So anyway, I can talk about this later on the panel, but the main issue is that we really needed to have a comprehensive approach and really meeting our patients exactly where they are and helping them shape the interventions that we should be implementing when we have actually effective evidence-based measures that can prevent us that can prevent HIV or that could actually cure hepatitis C. So I'll stop right there.
Great, thank you for that wonderful introduction and summary, and thanks for joining us today. We'll continue here across my screen. Dr. Berry, can you introduce yourself, please?
Yeah, good afternoon, everyone. Jim Berry, and I am an addiction psychiatrist, so board certified in both general psychiatry and then did a fellowship in addiction psychiatry. And have been working here in West Virginia since 2002. And I'm also the chair of our Department of Behavioral Medicine and Psychiatry. And my journey has been pretty much that of a clinician who's been treating folks with substance use disorders in Appalachia since the early 2000s. So when I first moved here, it was kind of interesting. Most of the people that we were treating who were coming in for requesting problems for their addiction were primarily alcohol, maybe some heroin problems, maybe some cocaine and some cannabis. But pretty quickly, we started seeing people come in for pain pill problems. And soon afterward, this trickle became the tsunami that we all know of now as the opioid epidemic that has been still raging since that time. And we've had to develop and adapt treatment models in order to really meet the horrible demand that is out there. And certainly we could talk about later how the type of substance has really shifted over time. And for some of the reasons why that may be, but I really try to communicate this problem that we're experiencing as an addiction epidemic as opposed to just an opioid epidemic. But it really comes down to addiction, and the substances will change and vary, and usually there's multiple substances involved. So much of what I do now, beyond the clinical work, we have very, very large outpatient medication-assisted treatment or medication for opioid use disorder program. That's somewhat of a novel program. And then also a lot of inpatient work, residential treatment, and some research. We're doing a lot of neuromodulation research in addictions right now through our Rockefeller Neuroscience Institute. So doing some deep brain stimulation and some focused ultrasound and transmagnetic stimulation as well to see if these modalities can be useful in our journey in trying to help folks who are suffering from addiction. Also do some teaching and a lot of advocacy. And as I'm sure everyone on the panel would agree, we still have a long way to go as far as what the policies that do exist in our local, state, and national government in order to really help those who are suffering. And so part of my role, I see as my role, has been doing a lot of stigma reduction and other education in order to help community members, help physicians, help teachers and judges understand what addiction is and dispel a number of the myths regarding addiction and really get everybody on board and equipped to help folks who are suffering. So thank you. Look forward to questions and dialogue.
Great, thank you. And thanks again for joining us today. Next up, Dr. Egleton, can you introduce yourself, please?
Yeah, sure. So to quote Monty Python now for something completely different. I'm a basic science researcher. So you may be asking what I'm doing on this panel. Well, I work at Marshall University in the med school, and I pretty much do all of the preclinical substance use disorder education, ranging from the pharmacology all the way through the behavioral treatments. I train expert. I'm involved in a lot of community things, including training foster parents who are going to be taking on babies that have been exposed to opioids in utero, so have had NOWs or NAS. So I have quite a good link with the community. The other area that I do quite a lot of stuff with is I teach across campus, so at communications disorders. One of the areas that we really focus on at Marshall is that every single person who may see a patient should be trained in appropriate approaches to those patients. So we train every single person in the College of Health Professionals and in College of Liberal Arts for psychology in basically the appropriate way to approach someone who's got a substance use disorder, you know, from non-stigmatizing language to, you know, all those kind of areas. So I'm involved in that training. We've recently just received a grant in conjunction with WVU and also the Osteopathic School of Medicine in West Virginia to increase the number of providers who are buprenorphine trained. So I'm involved in that, and my role in that is to train basically every medical student that goes through as far along the pathway as they can go before they leave us. So they only have to go in and do the final parts of the training when they get into residency. So that's something that we do in conjunction with WVU. Jim and I have been on a couple of panels together for a few years, so I've interacted with WVU quite a lot. From a research perspective, I have two primary areas of research. The first is really looking at the impact of opioids and on in utero exposure, predominantly in a rat model. And so we're looking at specifically development of the visual system for that. So you got some EFIS and all that kind of nonsense. I also collaborate with one of my colleagues who's actually in the audience as well, who's looked at GABAergic and glutamatergic synapse development under the same kind of conditions. And that's Chris Risher. I'm sure he'd be happy to answer any questions if you've got them for him. I also work with some of the pregnancy, opioid use in pregnancy programs that we have at Marshall, predominantly in patient education. You know, so we found that if they understand what's going on with their brains throughout the addiction process, it helps a lot, because obviously, you know, when you're doing treatment for opioid use disorder, everyone outside of the field is saying, oh, you've stopped taking drugs, you should be better now. And I think a lot of our patients believe the same thing and have a lot of self-doubt about why they suddenly haven't, like the mythical person who stops taking opioids and suddenly is perfect again. They all feel a lot of guilt over that. And so we found that a lot of patient education, actually explaining what's going on in the brain, kind of helps them. It's not that it sets them at ease, but it reduces some of the stress they have. So we've done quite a lot of work with that. The other thing I'm interested in is I've got a study where we're looking at reasons for dropping out of abstinence-only treatment programs. So we've got a residential abstinence treatment program in Huntington. And so we've been tracking, you know, clinical signs and symptoms, how they've stayed in the program. We've looked at cortisol levels. We found some interesting data which points to basically some things that have happened in childhood. So, there is some link with ACEs, especially, funnily enough, in the men. The strongest link we see is if you've been exposed to sexual abuse as a male, as a child, you're way more likely to drop out of an abstinence-based treatment program. So obviously trying to use that to say, should we be doing a much better trauma-based approach to treatment for those patients? So those are my primary areas of interest.
Great, thank you. We have such wonderful and diverse perspectives. This is going to be a really great panel. Rounding out the panel, Dr. Monti, can you introduce yourself, please?
Yeah, hi. Hello, everybody. Firstly, I'd like to thank the organizers of the panel for the invitation. It's indeed an honor to be amongst such an august group of experts. I have built my career here at Brown University, where I have, for the last 23 years, been the head of a research institute, the Center for Alcohol and Addiction Studies. And that center deals with all manner of addictive problems, and from basic research to actually treatment implementation research. We have nearly 50 faculty members, and we are 95% supported on NIH funds. A number of years ago, I began working in the area of brief interventions. And the brief interventions were focused on alcohol use in particular. And we did a lot of work in emergency room settings. And it occurred to me, looking at some of the incidental findings from those studies, that a number of people came in with either alcohol or drugs on board, had some kind of a sexual trauma experience. And it got us interested in alcohol and sex risk. And we did a number of studies sort of refining the brief intervention for people in emergency rooms to get them to address both their alcohol misuse as well as their sexual risk behavior. This led us into taking a look at a more seriously involved population of MSM, who are far and away above the growing population in the United States anyway, who are at risk for HIV. We did a few preliminary studies, and we eventually secured a center grant from NIAAA, the focus of which was alcohol and HIV. The center grant spanned neuropsychiatric areas as well as treatment intervention. One of the studies, for example, a more basic science study, was to take a look at people who were heavier drinkers versus lighter drinkers, and take a look at some brain mechanisms as a function of how long they had been drinking and the quantity of drinking. We measured such things as diffusion tensor imaging, fMRI, etc. Another study was taking a look at an adaptation of this brief intervention that we had developed in the emergency room and eventually used it in MSM populations for a very seriously at-risk population of men who were in treatment for HIV. And we were interested in seeing if reducing their alcohol abuse or use would have an effect on their sexual risk behavior. And indeed, we found not only a reduction in drinking, but also some signals that we were beginning to affect the transmission as well. We, in the second iteration of that grant, began to do more work integrating the neuropsychiatric findings from the initial studies into the feedback in the brief intervention to actually give individuals sort of feedback based on the profile that they sort of told us about with regard to such things as the extent to which they were engaging in heavy alcohol use. And one of the key elements of motivational intervention is to give people sort of appropriate feedback with respect to what they're doing as compared to their peer groups. We began to integrate some of this new neuropsychiatric information into this feedback, similar to what we heard recently about giving feedback to individuals about what their brain is doing under these circumstances. And we found that they were really very much attracted to this kind of feedback. And we took this to a larger scale in a in a step design, and we have just recently finished data collection there. Chris Kaler, my colleague, is the PI of that component of the center grant, and we're going to be taking a look at the efficacy of this intervention across several clinics around the country, including those in Miami, Los Angeles, as well as Chicago. In the third iteration of this grant, I've sort of stepped aside, and then sort of scientific director, and my colleague Chris Kaler is now the PI of the third iteration. And we're taking this intervention larger scale. We're doing dissemination and implementation work in several areas and many clinics around the United States. One of my colleagues, Sarah Becker and Caroline Kuo, are taking it to Cape Town, South Africa, where they're utilizing similar kinds of feedback, training individuals to do this intervention in the area of Cape Town and other South African cities. And so that whole line of work sort of inspired another project that I became interested in, because our Center for Alcohol and Addiction Studies has largely sort of been focused on psychosocial interventions. And in order to sort of fish in the pond of alcohol and HIV, I found myself outsourcing a lot of the necessary biomarkers and laboratory tests, which was costly in terms of getting quick feedback so that we could give it to our patients. And so I began looking into other venues to sort of build up a more biological sort of laboratory here at CAS, and CAS stands for the Center for Alcohol and Addiction Studies. That led me to apply for a COBRE grant because it provided some sort of infrastructure. And about a little over 2 years ago, we received our COBRE grant, the focus of which is, it's actually called the CADRE, the Center for Alcohol and Disease Risk Exacerbation. And my motivation for doing it was essentially to get the infrastructure to help sort of fuel our interest in alcohol and HIV. What it also enabled me to do is bring along a number of early career scientists. I am also sort of PI on a T32 training grant. We indeed have two T32 training grants. One that I head up is funded by NIAAA. A second is funded by NIDA. And so we have sort of an embarrassment of plenty in terms of postdoc, many of whom are successful in getting K awards. But as the senior people in the audience, I'm sure, are aware of, it's very different to be able to sort of earn a K award and then be able to transition from a K to an R. The CADRE grant was focused on helping people sort of make that transition from a very early career grant to a pathway toward independence. It was labeled the CADRE to give a sense of the sort of team approach that we have to training this next generation of people who are interested in substance abuse and chronic disease. And in fact, we've been blessed with a team of outstanding scientists who are in the process of transitioning. For those of you who have COBRE grants, you know that the sort of the defining positive characteristic of them is the number of people you transition to independent scientists. And the mark of that is typically an R01 award. And we have had 2 people in the last 2 years already make that transition. The projects in the CADRE grant span from taking a look at sort of the biology of alcohol and HIV in a project that's headed up by Molly Monig, who's a mentee of mine. Another one of my mentees is Haley Trailer Padovano, and Haley is interested in alcoholic liver disease and trying to get people who have already been so diagnosed to reduce their alcohol, at least address their intake of alcohol, to see whether or not we can affect some biomarkers in that disorder. We have other projects taking a look at smoking and HIV, and we have one rather interesting project that's in its infancy, taking a look at the potential for marijuana as a sort of a treatment approach in rheumatoid arthritis. So that gives you a flavor of what CADRE is about and a little bit about my background in this topic area. Thank you.
Thank you, Dr. Monti, and thank you everyone for those great introductory remarks and an overview. Wow, we have such a wealth of expertise and experience here. This is going to be a really fun panel. I'll go ahead and start things with a really general question, especially as I hear everyone talking about their exciting work and new developments. I'd like everyone to think about, what do you consider to be the most exciting recent developments in disease prevention among persons who use substances? And you talked about a number of things that I think could be real candidates for that. And then also, what are the most critical challenges for the field in the near future? So most exciting recent developments, and then also critical challenges.
If I might jump in, I think that people are very moved by getting sort of feedback about what's going on with their biology as a result of their substance abuse. And if this can be presented in a sophisticated way, sort of not to sort of put them down over this, but rather have them use it constructively in modifying their behavior, I think there's quite a bit of promise in feedback on the biology.
So I'll go in a slightly different direction there. I think it's really the fact that we're now focusing more on treating a patient rather than a disorder. So actually treating the whole patient, where whatever the comorbid conditions are, taking a trauma-based approach to treatment, making sure that any other health concerns are taken into account as well, rather than just saying, you are a substance abuse patient, therefore we are going to treat the opioid use disorder, for example, and then forgetting about everything else. So I think that's a really positive step forward.
Yeah, no, I agree with the comprehensive approach. And as I said, I come to this table because I'm an infectious disease physician, and my goal is to treat the whole patient, not just like what infections they're at risk for, but also really treating the substance use disorder. And I would also add, trying to think of creative ways that we can that we could have our patients use evidence-based measures, and also thinking about ways that we can address the fact that adherence is really hard. So if you talk about adherence to like medications for opioid use disorder, or even like adherence to like HIV pre-exposure prophylaxis, like we're now talking about injectables, which are really, to me, going to address some of that like adherence. It's hard to take a pill every day. So if there's a way for us to use an injectable that's gonna enable us to improve adherence, so that with medications and counseling, we can sort of have more people in care and saving lives.
Yeah, I'm tempted to say that the most exciting development is the neuromodulation research that we happen to be involved in, but that's because I'm involved in it, and this is what we're doing. And so, deep brain stimulation for opioid use disorder, for instance, which is very novel. But that underscores what I would say would be the biggest challenge. The biggest challenge isn't trying to find new and improved and fancy and sexy ways to treat addiction. The challenge is getting the treatment modalities that we already know are effective into the hands and the lives of human beings who are suffering from substance use disorder. And so there is a tremendous gap of just getting what is already evidence-based, as Sabrina mentioned, earlier, even with infectious disease. Like, we've got hepatitis C treatment that actually works. We've got medications for opioid use disorder that actually works. And so the biggest challenge is access to care and making sure that we've got a healthcare system that is equipped to respond to the need that is actually out there. And it's not necessarily finding new and improved ways of doing things. It's first and foremost getting what already we know works into the lives of people who need it. And I would also agree with Sabrina that, as from a medication standpoint, the fact that we do have some long-term injectable depot forms of some medications, such as naltrexone, such as buprenorphine now, and there's more developments, and that we should have another tool available roundly for us who are using buprenorphine to have weekly injections in addition to monthly injections here soon. So that is an important development that will help with compliance.
Yeah, I think if I might add one thing to that, it's obvious that several of us on the panel agree that taking the medication, compliance is a big issue. And I think a large part of that is something that we talked about just a few minutes ago, and that is taking a comprehensive approach. I mean, if you're trying to get someone to take a drug and they don't have a roof over their head, well, they're going to worry about not having a roof over their head before they're going to worry about taking that pill.
I think one other thing that that's really, and it was highlighted this morning by the talk actually from WVU, so I'll say congratulations to Jim because I'm sure he was involved in it, where they were talking not so much about the neuromodulation, but about using personal wearable devices to be able to potentially track when a patient is at risk from relapse. And I think that's something that it could be revolutionary if you can actually see real time where that patient is actually struggling, and then develop an intervention which helps them, basically prevents them from going into relapse. That could be a game changer. I mean, obviously, so especially because the technology for a lot of that is relatively cheap now. So I think that could be something that's going to revolutionize where we go, not so much in the initial treatment, but in the maintaining sobriety over the long term.
So in the recent vernacular, that's sort of referred to as the just-in-time intervention. And we're doing a fair amount of that work at Brown right now, using personal devices and sending people messages when they get themselves into risky situations. For example, when people who have problems with alcohol are in the vicinity of a bar, we had this thing tied into GPS, and they will get sort of try hard and reminders of what they had discussing in therapy, sort of as they approach that risky situation. We don't have sort of results of those trials yet, but we're in the field working that out right now.
Yeah, that also makes me think of the transition that many of us have had to do over the last 2 years of transitioning from in-person to virtual care. And that has been an absolute game changer for us. And if there's any silver lining to the COVID pandemic, it's the fact that we've been wanting to. At least my 5-year plan was to increase the number of people that we are treating for all of our mental health issues, by 10% in 5 years virtually. Well, in 2 weeks, we had to make it 100% is what we ended up doing. And so the genie is out of the bottle now. And all of those barriers that had existed, barriers from regulators, barriers from providers themselves, like myself, who may not have been comfortable and resistant to actually, going into the telehealth world, patient comfort levels. All of these things were just wiped away in the matter of several weeks, and so it really has given us the opportunity to reach and to retain people who would have a problem with transportation and getting to places where the treatment is.
Yeah, I would like to actually echo that and underscore, like, what are the lessons learned during the pandemic that we should implement forever? Like some of the, when you think about methadone, like what are the sort of regulations that were relaxed, and we've actually studied it and showed that actually patients did well and the system actually did okay. Like what are the things that we should be keeping and improving to increase patient care?
This panel is so good. They've already anticipated like 3 of the questions that I had prepared. So let's pivot a bit. One of the themes I'm hearing in this discussion is that evidence-based interventions exist, but implementing them and getting adherence to those interventions and getting them broadly disseminated are all incredible challenges. This is not unique to the substance use field. We see this in mental health. We see this in medicine more broadly. What are the unique challenges to implementing and disseminating evidence-based interventions in the area of substance use?
I think, to start with, some of the unique challenges is that most providers have not been trained historically in substance use disorders, so they're not familiar with it. And they think I think maybe for some, it just seems like, oh, that's just something else that I really am not able to address. And there's a recognition that the patients can be complicated and messy in ways that maybe some of their other patients aren't, or at least perceived to be. And of course, a lot of that has to do with stigma as well. It's really helping folks become equipped to understand truly what addiction is, and then it really isn't that difficult to do some of these simple things. And once you get set up to do it, on the other hand, as a physician who is treating substance use disorder, I have not done a great job of actually implementing the infectious disease treatment that is available, like Sabrina's talked about. And so we have our own ID specialists here who've been working with us to try to make it part and parcel of what we do. So, for every person who comes in who is at risk or currently has hepatitis, we do a good job of screening. And so we're able to identify a lot of folks who have hepatitis or HIV, but we don't do a good job of actually treating them ourselves in our program, which is something that, I could do, with the appropriate support. So I could see it from both ways, from somebody who's not used to treating addiction, it just seems like such a barrier to overcome, but also recognizing the reality, well, that is another modality that you have to learn how to do, you have to be equipped to it, but it's just getting over that initial level of ignorance or discomfort to actually start it.
I think another area that's a real barrier is you get it to a certain degree in larger cities, but in somewhere like West Virginia, which is pretty much rural, the ability for a patient to get to a treatment center is, and I think, as Jim said earlier, that's where COVID has kind of helped those people to a certain extent, because at least they can get their treatment over, via telemedicine. But the availability of behavioral health specialists in rural areas, you might have, a one-person family practice provider in an area, and they don't have the time that's required, that you need to sit down with someone who's got a substance use disorder on top of all their other patients, and they don't have the behavioral health support. So I think that's, the not just the psychiatrists, but the other health professionals who are involved in treatment of these patients, and the social workers who know where to send people. There's a real low number of other healthcare providers to help with the treatment.
I agree with the, level of comfort for the clinician, right? Like, this is someone else's problem. Like, this is not what I was trained for. And so one solution to that is going at the medical school level. And I know that a lot of medical schools, especially I'm familiar more with Massachusetts, but really making it part of the curriculum so that all medical students, as they're going through the system, and also the PAs and a nurse practitioner, feel very comfortable starting patients on treatment. And also the other thing is, for the older clinicians, how can we support them? And I know that our general internists and addiction medicine specialists actually have set up like a hotline. There's actually a hotline that, as a clinician, you can just call and be like, okay, I have this patient, these are the issues, can you help me? So that we can really have a low threshold and low barriers to even initiating. And then maybe you can send them to, like, someone else who can carry on, but at least making a lot of people more comfortable with starting treatment.
Yeah, one other thing related to that, the response of a lot of places is to say, we just need more people who could prescribe buprenorphine. And prescribing buprenorphine is helpful, but if you don't have it with the appropriate other aspects of the treatment, it's not as useful as it could be. And I think that's something that has changed, at least at Marshall, where they've now got the understanding that we have to make sure that we're not just treating this as something we can throw medicine at, that we actually have to treat this more as a all-round disorder rather than just, oh, if we give a drug to treat it, it's going to be okay.
Yeah, I totally agree with that, Richard. And, keeping in mind, we don't have medications to treat methamphetamine use disorder, for instance, or cocaine use disorder, or cannabis use disorder. And so, really seeing addiction as multifaceted, bio, psycho, and social, and really emphasizing how important these other modalities are beyond medication if we truly want to change lives.
Great. Well, Dr. Berry raised the issue of COVID, and we can't have a panel in 2021 without talking about the impacts of COVID. And it was actually brought up in the context of some silver linings, which is exactly the phrasing that I had in my question. But are there also consequences of COVID or disparities that have been exacerbated or concerns going forward? So maybe the panel can talk a little bit about both the extra challenges that COVID poses and in its aftermath, and then also some of those silver linings.
Well, the obvious challenge is that substance use is up since COVID has been with us. And so we have a much bigger problem than we had prior to COVID in terms of the number of people who are misusing substances.
Yeah, unfortunately, prior to when March hit us, 2020, is at least in my own system, I was trying at my best to communicate to anybody who would listen is, please, 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 let's not shut things down. Let's be very, very careful about what we are doing here and the impact that isolation has on people who are at risk or who have substance use disorder and or mental illness, additional mental illness. And sure enough, what we saw was a lot of programs shut down, a lot of community support places shut down, and we saw a skyrocketing in the degree of severe psychological distress. And we saw a 30% increase in the overdose deaths nationally. West Virginia, we had a 50% increase in overdose deaths. And so one of the horrible consequences was, and I hope that we will learn our lesson for what our strategies will be going into the future, is when you isolate people and you prevent them from getting around other human beings, there are going to be dire consequences to that. And there are things more important than just preventing a viral transmission.
Yeah, so I was in one of the sessions earlier today, and Dr. Collins, and I can't for the life of me remember what institution she's from, but she was talking about the impact of COVID-19 basically on the homeless population. And a lot of that was related to the fact that, homeless shelters changed all their rules and all that kind of thing. And there was considerable social isolation amongst that patient population. So it's crossed, I think COVID has specifically hit the high at-risk population much harder than, people like us. Yes, I mean, I'll freely admit when COVID hit, my alcohol consumption probably went up for the first month or two, but then you kind of get into the swing of it and it went back to normal. And I think that's probably true for almost everyone. But I'm in a stable situation. I have a house. I have decent coping skills. If you don't have those kind of things, you could see how that could just really kind of spiral out of control. And I think that's what we saw.
Yeah, the other thing I would say about that is you're right, Richard. It was those who are most vulnerable had the least amount of reserve. That once you created this more stress, then that reserve was gone, and it really put a spotlight on the fractures that do exist. But the other thing that is at top and forefront of my thinking, especially lately, is how the pandemic has affected healthcare workers. And so for those of us who have actually been working and not gone home, but actually have been working on the front lines, and not just physicians, but especially nurses and social workers and others, it's been devastating to see the trauma and the degree of deaths. So not only the deaths that occurred with patients who had COVID, but also the increase in the overdose deaths and other consequences that are side effects of our response to the COVID crisis. And so that has taken its toll. And, unlike other traumatic events that have occurred, you think of, a hurricane or SARS or a war, there's been no end in sight so far. We just thought we were going to be able to get back to normal, quote unquote, and then the Delta variant hit, for instance. And then we saw a surge in the capacity problems, the rationing problems, et cetera. And so that's created another degree of just moral insult among a lot of the healthcare workers. And I would say, I would identify actually healthcare worker burnout, wellness, mental illness as the number one health crisis that we are and should be paying attention to going forward. Because if we don't, then nobody's going to be able to get help because the system's going to crash.
I would just like to emphasize that those underserved in our society have been affected the most, mostly because they haven't had the luxury of working from home. They were the bus drivers. They were the people working in the fast food industry. These were people who had to go to work and confront exposures. And we know that COVID took a disproportionate sort of hit on this segment of our society. And whatever we can do to ameliorate that situation the next time we're dealing with such a crisis, we'll be well served for having done so.
So the panel has again presaged some of my questions very nicely. And I want to follow up particularly on the question of providers and how do we combat this fatigue, burnout, frankly, trauma among providers, especially given the unique nature of this particular pandemic and how, as Dr. Berry said, there's been no end in sight and it's been constant and just so all-consuming. So how do we combat that and support our healthcare workers going forward?
I think one thing that would help would be a consistent and rational message from various state, county, and government officials. I'll give you an example. A lot of my friends at Marshall, they've got kids in Cabell County, and every time Cabell County goes below a certain number of cases, they say, "Oh, no face masks at school." They have face masks off for a week or 2 weeks, and then they have to have them back on again because the case number's gone up. So I think that's putting a lot of, for whatever political reasons, it's putting a lot of stress on people who are healthcare workers who have that kind of worry that they shouldn't have to have about whether their kids are going to be safe. I mean, my daughter's been wearing a face mask the whole time, but still, it's still that worry. So I think, and that's just an example, just a consistent message from whether it's the state or whatever government level of leadership. If you've got good leadership, that helps. I think at the moment, there's so much misinformation that I think it really freaks out patients. And when the patients are freaked out, it kind of basically goes on to the healthcare provider is the person who gets the brunt of it. So I think just from a basic standpoint, a consistent, clear message.
Yeah, no. So wanted to also, first of all, even before COVID, there was burnout amongst clinicians, right? Even before that, you guess who has the highest rate of suicide, right? Like physicians. And so this was actually a problem before COVID, and now it's actually been exacerbated with, these repeated increases and demand from healthcare workers. And I'm hoping that there's going to be actually a change with COVID, because a lot of the times the solutions I would propose often were not generated from like the people impacted. Like, for instance, I'm just talking about my hospital. We were told to just do yoga or meditate, right? When if you talk to clinicians, they'll tell you the big burden is all the documentations that we have to do. Like a lot of us spend, because of all the rules and everything, a lot of us spend like weekends and evenings documenting things. So that this was one source of burnout and stress. And going to do some yoga or meditation is really not going to help that. So I'm hoping that what COVID is doing is really bringing to the forefront clinician burnout and really shifting it so that we're actually listening to clinicians, asking them for solutions and understanding really what is happening, as opposed to having these proposals that really are not going to be helpful, because we're heading to our major crisis. Because if you think about, the nurses, the social workers, the physicians who really are burning out and leaving the field, we're going to be in trouble if we don't address this relatively quickly.
Yeah, well said. And that is absolutely right. This was a crisis before the pandemic. It's become the pandemic has exacerbated what was already a really precarious situation. And it takes both individual level solutions and system level solutions. And like Sabrina had mentioned, again, much of what has happened heretofore has been telling the physician or the clinician, the nurse or whoever it is, you try this, whether it's yoga or mindfulness, which all, very much could be helpful, but it's not enough. And we need to reevaluate and reorganize the system so it frees the clinician to be able to live and work in a safe environment and one that is fulfilling. And so, as already mentioned, at least I didn't, I'm sure Sabrina didn't, or Peter, or whoever, did not go to medical school expecting to, spend 3 hours, 4 hours, 6 hours a day in an electronic medical record or on the phone with insurance providers to try to get prior authorizations, or, all the other billion, what I call stupid stuff that we have to do each day. And so it needs to take a hard look at why are we having our, people with advanced degrees doing this kind of work, and how do we free them up? The other thing is, we know that what's fulfilling is autonomy, mastery, and purpose. And so giving people the flexibility to work the type of hours that are going to be still productive, but at the same time, not soul killing. And you don't feel like you're on a hamster wheel running 100 miles an hour for 10 hours a day, and without any breaks, et cetera. The other thing I think is really helpful in what I've been trying to do is really foster a team-based care as much as possible, that there's safety and strength in numbers. And whenever we can attack a problem together, it's a lot easier and sane than trying to do it on our own. So those are just some examples, but it really takes committed leadership for our hospital systems, our health systems, to be able to do it, and not just put the burden on the individual provider.
So to tie this conversation in with the general theme of the panel, do we know if substance use is on the increase among our healthcare workers?
So we know that for sure it has been among the general population. And at least with some surveys, we've done some internal surveys too, which are a little bit tricky, right? Because, even if it's an anonymous, there's still a part in the back of your brain is like, who's going to read this? But even in the anonymous surveys, we've seen at least increase in alcohol use, which is entirely consistent with the general population. Not so much with other drugs, but I would be willing to bet that, yeah, there's been an increase in other drug use too.
So let me ask you a more difficult question. Why are so many of our healthcare workers anti-vaccine?
Well, so actually among physicians, there's a pretty high rate of compliance with the vaccine. The nurses, at least the data I saw a couple of months ago, was not as high. And I don't know the answer to that. Maybe somebody else can speak to it, but at least among the physicians, the rate is pretty high.
I would hope so.
Yeah, no, so I agree with you. Physicians, some of the numbers that I've seen was like 96%.
Yeah.
I was actually wondering who those 4% were.
Yeah.
Like, who are you?
Yeah.
So, and amongst the nurses and other healthcare workers, it was lower. But you know what increased it? The mandates. At our hospital, we shot up from, being not so great. And actually, I was a little bit worried. We got up to 98% with the mandates. Again, in healthcare, you're right. Like, in healthcare, we've had mandates for like ever, ever since I was a med student, I had to get my Hep B vaccine from the day one. And so we used to mandates. And, because the vaccines were relatively new, there were obviously some reservations, but once, at least we had one that's FDA approved, the rates kind of went up. Unfortunately, I think like one of the major reasons is all the misinformation. I mean, there was just so much misinformation from like the get-go that sometimes it's really hard to sort of tease things out. But I'm glad that the mandates, from my sense, has actually improved adherence to the vaccine, because, as a patient, especially as a patient who's immunocompromised, you shouldn't worry about whether or not the healthcare worker who's going to take care of you, is going to give you COVID. Like, you shouldn't have to worry about that. And I'm glad that a lot of health systems actually implemented mandates so that we can protect ourselves and also protect our patients.
Yeah, I think also one of the things that's happened, I mean, so we have the mandate at COBRE, which goes into effect fully, I think, in a couple of weeks. But in the general university population where we are, they've basically said, if you aren't vaccinated, we're going to test you very frequently. And the testing is so obnoxious that I think after a couple of times, many people actually think I'd kind of rather be vaccinated. So I think there's a number of things. I think the reason why people don't get vaccinated is probably because a lot of the misinformation, and it kind of became a political standpoint in the end. And I think that's people just dig their feet in and say, I'm not doing it. And it's not just over here. They have similar problems in Europe, so it's not just an American issue. It happens in Britain and across Europe as well. So.
Yeah, and not just the end, right, Richard, but it became politicized from the beginning.
Yeah, exactly.
Right. And on both sides of the political spectrum. So there isn't like just one group to blame, but it certainly caused huge problems that we're still having to deal with today by virtue of what we see with the poor uptake among general population and some distinctive workers too.
And there's also there's a lot of, I mean, I get asked a lot of questions by students at the university, and there's a lot of misinformation still about whether my family had COVID already, so they're not going to get it again, they're protected. Whereas the evidence says they should still get vaccinated because they're going to be better protected. I've had a vaccination, I can't pass it on. Well, no, that's not true. I mean, there's so much misinformation, and there's so much news on it, people just stop listening.
I find the regional differences just very fascinating.
Yeah. Well, West Virginia is definitely regionally different.
Yeah, and we've got, the last numbers I saw was this morning, 51.6% vaccinated rate.
Yeah.
This is great discussion and really great insights on these topics. I did want to change gears and ask one more question before we pivot to some questions from the audience that have been coming in. One of the themes that I noticed from some of the earlier discussion about kind of exciting new developments and treatments is the ability to individualize treatment. Dr. Monti and others have talked about providing individualized feedback or tailoring interventions for individuals. I'd like the panel to speak a little bit about that idea of really personalizing and individualizing treatments and where we think that's going and the potential to improve the effectiveness of our interventions and maybe the acceptability of those interventions as well.
Yeah, I mean, you're hitting on the fact that one size does not fit all, and that we as human beings are complex creatures, and that we're multidimensional. And really, there has been a shift, a much needed shift over the years to really focus on that and the patient-centeredness of care. And also doing measurement-based care as well. There's another there's more value into trying to get as much data as we can from individual patients that we're able to kind of track over time and seeing how our interventions are working. So yeah, very important topic.
Yeah. Oh, sorry, Karen.
Sorry, go ahead, Richard.
What I was going to say is every person goes into substance use disorder for a different reason, and until you can get to that root cause of why someone decided to take opioids, I mean, whether it was some kind of back pain from an injury, whether it was to self-treat some other kind of disorder, until you get to the root cause, you can't really treat. You're always leaving them open. Even if you get them off, you're leaving them open to relapse much easier. So understanding the root cause of why someone's going into addiction and what's driving it is pretty important.
Yeah. What I was going to say, I think would sort of enhance that by noting that assessment is such a key part of the picture, and as our assessment instruments improve, I think we'll be better able to target the right treatment for a particular problem in a given patient. And that includes not only sort of psychosocial assessments, but also sort of biomedical assessments of various biomarkers. And the extent to which we can come up with rapid assessment of the problem, we can then go in and target the specific issue for that individual. For example, understanding the role of sexual trauma in substance abuse is hugely important. But getting a handle on that and being able to sort of turn it into a positive treatment sort of prescription is, of course, the key.
And this might be an ideal opportunity to pivot to our questions from the audience, because the first question submitted actually is related to this topic. So this is a question for Dr. Monti. It said, in one of the first studies you mentioned in the introduction, which specific mechanisms did you look at in high versus low frequency drinkers, and what did you find? So maybe some more information about the details of that study.
Yeah, well, I think in that study, if it's the one that was the imaging study, we are at this point still grinding the data down, taking a look at different areas of the brain that might be affected by heavy versus light drinking, and the extent to which there are some similarities in the brain of people who are drinking heavily as compared to similar differences in the brains of individuals who are HIV positive, and the differential effect that heavy drinking has on people who are positive versus the same effect of that heavy drinking on people who are negative. This is what we're looking for. We've not yet sort of gotten to the analysis phase. These imaging studies are incredibly labor intensive, but we hope to be able to make some intelligent statements about the effects of alcohol on brain, and not only on brain, on gut as well.
Great, that's really exciting. Some more, look forward to those results. The next question is for Drs. Assoumou and Egleton, and any other panelists who work with HCV. To what extent have you seen unnecessarily lengthy, complicated prior authorization processes serving as a barrier for scaling up prescription of direct-acting antivirals?
Yeah, no, this is a huge problem because the Hep C drugs, they actually can cure patients, but when they first came out, they were very expensive. And so the way that the insurance companies sort of wanted to clamp down and sort of limit the amount of spending that they would have to do is having these really lengthy prior authorization processes, which are and also different requirements. Depending on what state you were in, you would have to follow different, like either sobriety, like criteria, or even like certain clinicians weren't allowed, like you had to be a gastroenterologist in certain states. So there's definitely been the prior authorization process has definitely been an important barrier. It's getting better, but it's still a major and important barrier.
Oh, I have nothing to add to that.
Sure. We go on to another question then for Dr. Berry. Do you know the plan for HIV screening in West Virginia?
Do I know the plan for HIV screening in West Virginia? No, I don't know of a plan as far as a statewide screening plan. Unfortunately, I'm not privy to that information.
Okay. We have another question that goes back to the discussion of better substance use training at the medical school level and asking, how do we get the resources for these high degree professionals, MDs, doctorate level psychologists, et cetera, to actually make it to the most vulnerable patients who are, say, under-resourced methadone clinics who are at those settings? So how do we get those resources out to make it available to more vulnerable patients, I think is what the question's asking.
I mean, so I think I'm guessing they're asking, how do we get the training to the people who are providing that? Yeah. I mean, one of the other issues that COVID did was it, at least for Marshall, reduced in-person CME a lot. So a lot of this is, if we train the medical students, that's great, but you know, we've got a couple of generations of MDs, psychologists, social workers, what have you, out actually, I guess on the front lines, actually doing a lot of the work. Really, I mean, it's going to be I suppose one of the best ways to do it is make it part of the boards. You know, if you're forced to actually have to know about that for your boards, at least you're going to read it. CME, those are the areas. I know WVU has a really good program through their WV-CTSI, you know, from a research perspective, getting the rural clinics involved. And so you could use those kind of networks. But I think it's really the medical schools reaching out and providing appropriate training, or the psychology programs are providing the appropriate training. And of course, that means money. So we try. You can provide these things, but the people have to be willing to come, and it's a lot of it's timing. You know, it's really easy to do a nice simple CME online where you've just got to read an article and, you know, click a couple of buttons. But to actually get something out of this, it's really more than just reading something and doing it. You actually have to do things in person and discuss it, and many physicians, especially at the moment, just don't have the time.
So yeah, I would see there's two audiences that need to be addressed, which Richard elicited, is that one is the trainees, so those who are in medical school as one example, or nursing school. And that's where we really need to have the national federal mandates come down and say, yeah, in order to graduate and have a degree in medicine or nursing, you need to have X number of hours trained in substance use disorders. And so the universities are not going to change until they're told this has to happen, and they need to do that. So that would be, I would say, the priority. And so that takes some political will to make that part of what they're required. Just like as mentioned earlier, mandates do work. This would be a mandate for the health system, for the universities. And then the other audience is the practicing clinician. And so you know, so CMEs are absolutely fantastic. And as mentioned by Richard, you know, we've got the opportunities to do so more with all of the virtual offerings that exist now. One of the things that's available across the country, and WVU Marshall's part of this too, is ECHO, which is Extension of Community Health Outcomes, a wonderful model that started at the University of New Mexico, specifically addressing hepatitis C treatment early on. But basically what that is you have specialists usually located at an academic medical center, but doesn't have to be. And they have regular sessions with any provider in local communities and provide a brief didactic. And then also the provider in the local community is able to bring their cases, and then there could be some shared discussion and decision-making regarding a particular case. And that has been very, very fruitful in addressing some of these scarcity of expertise resources in areas where they don't have it. We really are extending the specialist reach by empowering the local provider to do that. And as one who's been participating in that for a while, I could also say it's very rewarding. And it's been a thrill to be able to, I learn things every day when I do it, but also watching the local providers become more confident and adept, and they get excited about the fact that they're able to do it. They just need the support, some comfort that there's always also a safety valve that they could call, between visits if they need to.
I'd just like to emphasize the importance of this issue. There's so much misinformation out there that's sometimes perpetrated by our most esteemed colleagues. I still address physicians groups on occasion and find some resistance to the belief, which a number of people have, that you should advise your patients that if they drink, they shouldn't take their antiretrovirals. That's wrong. They're going to do more harm by not taking the antiretroviral than they would do by drinking and taking the antiretroviral. And that kind of thing is out there and still being, passed on to our patients. So I think education of the frontline folks and the professionals who are running these organizations is really essential, and to sort of make it part of the job to absolutely make it essential that they keep relatively up to date with what the science is.
Great. We have another question that's following up on the discussion about burnout among providers. And the question asks, how do we support peer support specialists? Peers are asked to create unique relationships with their clients and experiencing catastrophic levels of experiential and secondary trauma. So how do we support those peer support specialists specifically?
Yeah, the peers are critical, and there have been a number of efforts and examples of having peers in the healthcare setting. So, having a physician peers or nursing peers that are available and at hand when needed for their colleagues who are in distress. And so it's absolutely a demonstrable benefit to have a well-ordered and supported system that's producing this. I mean, the challenge is actually having a healthcare system that'll have the buy-in to understand this and provide the necessary administrative support and time, for the peers to be able to do the work that they're doing. But it makes a huge difference.
Okay, thank you. We have another question that asks, how do we change stigmatizing language used by healthcare personnel, everyone from clinicians, reception, nursing, other support? Is there a feedback loop to address continued non-compliance among personnel? So how do we address and change stigmatizing language?
So I can tell you from our perspective, what we've done is pretty much all of our healthcare professionals go through a non-stigmatizing language training. So, I mean, we have 2 hours on it for the medical students in the first year of medical school, and continually do it throughout the time. The problem is like not some of the more senior providers still use language which, on the face of it doesn't sound too bad, but you shouldn't be calling someone an addict anymore. So they don't necessarily see anything wrong with it, but it's still stigmatizing. So I think typically we've got feedback from students that we can, we'll then approach providers if they're doing the wrong kind of thing. But I think it's a huge issue. The other thing that we've done is we've also provided for the local press basically a translation document. Instead of saying an addict, it's a person with a substance use disorder. So the way that we can try and get not just the healthcare providers, but the local press and all that to try and adjust their language. The biggest problem is it's like anything. People are used to using language, and it's a really hard barrier to cross.
Yeah, I would totally agree, Richard. And I think it's very important to sort of address it at the minimus level, so that if there's a microaggression, deal with it at that level before the conversation sort of embellishes on these microaggressions to the extent that you're really, putting your foot in your mouth. At a place like Brown, you just don't get away with anything here. I mean, we don't have a freshman class here at Brown. We have first years, and I can imagine that you'll understand why.
Okay, we actually have made it through all of the questions submitted by the audience. So certainly audience can continue to submit questions and we'll try to get to those. But given that we have a little bit of time, I want to ask the panel, what is the question that we haven't asked yet that we should ask, or that you'd like to talk about? Or if you'd like to ask a question to each other, please do that now.
Well, a question that we grapple with in our center is the role of psychiatric disorders and the extent to which they fill the bill when studying the relationship between substance use and chronic disease. And so do we treat a psychiatric disorder, for example, depression, the same way we treat HIV or rheumatoid arthritis, or is it somehow different, and we should be approaching that diagnosis a little differently?
I'll take a crack at trying to answer, because it's complicated. And so first thing I'll say is that addiction is a psychiatric disorder. And so first and foremost, when we're looking at substance use disorder, always remember that it is a psychiatric disorder. It's in the DSM-5. And so I try as much as possible, in thinking about language, I try not to say mental health and addiction, but addiction as a mental health problem.
I noticed that in your earlier comment.
There you go. See, you're very attentive. It's where I'm trying to pay attention to my own language. And so I think that's really, really important for people to understand, because at the same time, I think we can over-medicalize substance use disorders. And I think there's dangers in that too, because recognizing that, listen, as much as we can use and appropriately use diabetes as a good, especially type 2 diabetes, as a good analogy to substance use disorder. So it's a chronic relapsing condition that has an organ that's been affected, that also has psychological and behavioral components to the manifestation and the development and the outpouring of the disease itself. But at the end of the day, substance use disorder is not diabetes, and it's something distinct, and it's going to have its own host of implications, complications, and treatment options. And so I think it is important to do that. The other thing is we've created a healthcare system, and we've created a healthcare system historically that separates mental health from general medical conditions. And that's why I'm also really concerned about changing the narrative, because we've done the same thing with addiction and other mental health conditions too. So we've separated those out. But if we really want to try to work toward an integrated care system, and that means if we want to be able to truly help somebody with diabetes, for instance, then we have to help them with their behavioral health stuff. There's a lot of comorbidities between diabetes and major depressive disorder, for instance, trauma, just like there's a lot of comorbidity between opioid use disorder and PTSD and depression. And if we fail to appreciate that, and if we don't try to get as much as possible co-occurring care, we are going to not solve, or we're not going to give the patient the best care possible. We're going to miss things. And we might be able to help somebody with their diabetes by getting their sugar under control, maybe, with insulin. But if we're not helping them with the trauma they've experienced, then actually their diabetes probably won't get that much better, even if we are helping some with the glucose. So just some quick thoughts that come to mind.
I think also there's you're seeing a lot of data now about things like the microbiome, which brings into the idea how important is a good diet, because we know that the diet regulates the microbiome. And one of the issues we see is that a lot of people with substance use disorder have a really crappy diet. And how is that going in? So just basic ensuring that nutrition is appropriate in the patients. How far can that go? We know that the gut microbiome has been linked to depression, anxiety, but basically almost all of the other mental health disorders that have been linked to substance use disorder. So there's a huge potential avenue for treatment via appropriate diet, probiotics, that kind of thing, which, in some ways, big pharma's not going to like, because a good diet is really cheap compared to whatever drugs they're going to do. But, I think it's an area that could be of huge importance, because regardless of what else you're doing, if your nutrition isn't appropriate, you're going to have issues anyway. So.
Yeah, I see it as almost analogous to the need to have, a roof over your head. I mean, some of these very basic things are things that we tend not to pay attention to, that could be hugely influential in these disorders.
Yeah,
I'm really.
Oh, sorry. Go ahead.
Oh, go ahead, please.
I was gonna say, talking about having a roof over your head. I mean, when we went to the detox and we were interested in either, testing patients and linking them to like care to address either HIV prevention or Hep C or substance use, we found that 30% had unstable housing. And that was like their main issue. And they're like, I'm not interested in all of this. Like, I'm wondering where I'm going to sleep when I leave the detox. And so what we realized, that's why we talk about that comprehensive approach. If I don't address like the main issue that the patient has, everything else that I'm trying to offer is not going to work. So the importance of really addressing the social determinants of health, such as housing.
There's some really innovative programs that are beginning to look into this. I know at the University of Washington, they were looking at protocols that involve providing housing for substance abuse problems.
Yeah, I'm really enjoying this discussion of thinking about and treating the whole person and everything that's going on in people's lives, and not separating their substance use from other behaviors or mental health issues or things that are going on in their lives. I think that's just a critical piece that historically has been really underappreciated. And I'm really glad that leaders in the field are advocating for that approach. It's really great to hear. We do have one more question and a few minutes left, so I'll read that question. How well do you believe that our treatment systems accommodate use moderation as opposed to abstinence? What do you think needs to be done to better accommodate patients who are not interested in abstinence?
Well, it really comes down to trying to address the particular patient's needs. So, I mean, I think most of I'll speak for myself. So, when I see a patient and I'm going through their history and I'm trying to determine and diagnose what their problem is, and it's clear to me that they have a severe alcohol use disorder, for instance. Usually what I will do is have a conversation with them. I try to use as much as possible motivational interviewing. And so I'm trying to elicit what are their reasons why they may want to make a change, and then also try to provide, with their permission, the evidence that I have that would suggest that really in their condition, the best thing for them would be to quit drinking and to not try moderation drinking. But not everybody wants to do that, especially straight out and first into treatment. So then it's okay. Well, let's have a plan. Let's have a strategy. what would you say would be reasonable amount of drinking that you want to try to test yourself and see what works? Okay, let's give a trial of that for several days, several weeks, several months, whatever you're comfortable with. Because at the end of the day, it's your life and it's your body, it's not mine. And you're gonna be the one that lives with the decisions you make and what you feel like is the right thing for you to do. And so if you try to drink in moderation and it works for you and that you're satisfied with it, and then you're not having any problems that you identified or others in your life have identified with it, then okay, these would be the risks to your liver if you keep doing moderation drinking. Some people will decide, yeah, I just couldn't do it. I realize that I'm a different animal and I just need to stop drinking. Others who I would put these folks in the category of at-risk drinkers or maybe have a mild alcohol use disorder is, yeah, that they could try to do moderation drinking and it can work for them and they could still be happy and fulfilled and functioning. But in my experience and what I understand the data to be too is once somebody's really reached moderate to severe alcohol use disorder, for instance, then really helping them stay off alcohol completely is going to be the best health recommendation that I can offer them.
Yeah, I learned a fair amount about this in some of the work I did earlier in my career with adolescents. To preach abstinence to adolescent drinkers is like whistling in the wind. So very much, agree with Jim. You need to meet people where they're at, and if they don't want to hear abstinence, then you got to figure out where on that scale they are, and sort of pitch to that level.
Yeah, I mean, the other thing to consider is again trying to get an individual patient, but why are they coming to you and what is at stake? So for instance, if I treat a number of healthcare providers, I've treated, physicians, since I've been here. And once they get into problems and it's become recognized and they've gotten DUIs, they got to go before a medical board. And you cannot do moderation drinking. Same with pilots. There is a hard line and it is a public health concern if this person continues to drink. And so in that case, it's like, yeah, if you want to keep your job and you want to keep your license, you got to be abstinent and I will help you be abstinent. But there are other forces. My point is there are other forces at play that really dictate what the treatment options could be.
We have just a couple minutes left. And so I want to see if any of the panelists want to offer any concluding thoughts. This has been a great discussion. Anything the panelists would like to add?
Always my concluding thoughts whenever I have an audience is to help people understand that addiction, substance use disorder is entirely preventable and treatable, and give people hope and that understanding that, yeah, this is a disease, this is a condition, a disorder that we absolutely have the tools to prevent and both treat. It's just having the will to provide the resources and access to both the prevention and the treatment that's out there.
Yeah, and so just echoing the theme that we've had, like the importance of a comprehensive approach, right? Like it's really hard we really want to have important and helpful outcomes. You really need to think of the whole person, what are the mental health issues? What is the substance use issues? What are the other comorbid conditions that are actually occurring at the same time? And how can we sort of craft a treatment approach? But also the importance of meeting people where they are, right? And I mean also not just where they're like physically where they are. A lot of the times, as physicians, we're like in our little towers at the clinic and wondering why they're not coming to us, right? And we need to learn that we actually have to go where the people are in the community. For instance, that's why we as a study side pick the detox, because that's where we can actually reach patients who are thinking about recovery and are interested and probably more open to hearing what we have to say. And also the importance of low barrier access, right? Like you don't want to have people jump through many hoops, especially if they come to you and they're like, I'm ready. Like you don't want to have to go through like many layers of testing and follow-ups, and just, just use that opportunity to sort of start patients on something today. And if as a clinician, you don't feel ready, like, who is it that you can contact to help you start that, medication for opioid use disorder today and right now?
And I think one thing that I'd like to say, which I don't think we addressed today, was you take this as a culturally sensitive approach. You have to know your patient population before you can treat them. Something that might be appropriate in Boston probably isn't going to be appropriate in Parkersburg, West Virginia, for example, the way you approach the patient. So you have to know the population you're dealing with to be an effective provider for that population. And I think it's true for every medical disorder, but it's particularly true for substance use disorders.
Yeah, I agree with what my fellow panelists said. I would just like to take this opportunity to thank you, Tim, and the audience for some excellent questions and a fun afternoon. So thank you.
Well, and thank you again to our panelists and our audience. This was a wonderful discussion. I know I learned so much and have so much to think about from this. This was really great. So thank you so much. And one of the unfortunate things about being on Zoom is we can't give a really good round of applause. The little symbol you put up just doesn't do it justice. But I want to say, if we were in person, we'd give a rousing round of applause. That was really great. So thank you, everyone.
Bye-bye.
Thank you.
Thanks.